problem posed in many epidemiologic studies is that we observe a true association and are tempted to derive a causal inference when, in fact, the relationship may not be causal. This brings us to the subject of confounding, to one of the most important problems in observational epidemiologic studies. What do we mean by confounding? In a study of whether factor A is a cause of disease B, we say that a third factor, factor X, is a confounder if the following are true. 1. Factor X is a known risk factor for disease B. 2. Factor X is associated with factor A, but is not a result of factor A. Recall the example we discussed in last class of the relationship between coffee and cancer of the pancreas. Smoking was a confounder, because although we were interested in a possible relationship between coffee drinking factor and pancreatic cancer disease B, the following are true of smoking factor X1. Smoking is a known risk factor for pancreatic cancer. 2. Smoking is associated with coffee drinking, but is not a result of coffee drinking. So if an association is observed between coffee drinking and cancer of the pancreas, it may be 1. That coffee actually causes cancer of the pancreas. Or 2. That the observed association of coffee drinking and cancer of the pancreas may be a result of confounding by cigarette smoking. When we observe an association, we ask whether it is causal or whether it is a result of confounding by a third factor that is both a risk factor for the disease and is associated with the exposure in question. We usually select potential confounders that by themselves change the main effect by 10% or are known risk factors for the outcome according to prior evidence. How can we address the problem of confounding? As seen in the figure, the issue of confounding can be addressed either in designing and carrying out a study or in analysis of the data. In designing and carrying out a case control study, we can match the cases to the controls by either group matching or individual matching for the factor that we suspect could be a possible confounder. Alternatively, we can handle the problem of confounding in the data analysis in one of two ways: stratification or adjustment. We can carry out a stratified analysis with subjects and subgroups. If the relationship between exposure and disease is true, and not to the confounding effect, then in each stratum of urbanization the incidence of disease should be higher in people with the exposure than in non-exposure. It would then be clear that the observed association of exposure and disease could not be due to confound. On the other hand, we can adjust the confounders in the regression analysis. 2 final points on confounding. First, when we identify a confounder, we generally consider it a problem and want to find ways to address the issue of confounding. But sometimes finding a confounded relationship can also be very useful. For even if the apparent association between factor of the factor in which we are primarily interested and disease B is actually due to some third confounding factor X, so that factor A is not causally related to disease B, screening for factor A can nevertheless be useful because it permits us to identify people who are at high risk for the disease and direct appropriate preventive and therapeutic interventions to them. Thus, a confounded relationship may still be a helpful guide in screening populations even when we do not identify the specific etiologic agent involved. Second, confounding is not an error in the study, but rather is a true phenomenon that is identified in a study and must be understood. Bias is a result of an error in the way that a study has been carried out. But confounding is a valid finding that describes the nature of the relationship among several factors and the risk of disease. However, failure to take confounding into account in interpreting the results of a study is indeed an error in the conduct of the study and can bias the conclusions of the study.